we are almost 5 minutes late, but our is a very important one for our day-to-day practice, the Epiphora. The A to Z care of the Epiphora, we know that lots of our patients in our day-to-day activity suffering from Epiphora. So what are the pillars of success to eliminate the Epiphora? With us, our lots of speakers are with me, Dr. Jayanta Kumar, consultant, Gangaram Hospital, New Delhi, Dr. Salu Bageja, senior consultant, Gangaram Hospital, Dr. Nilanjan Kaushik Thakur from Associate Professor, Silchar Medical College, myself, Dr. Amrita, another senior consultant from Gangaram, and the expert, Dr. A.K. Grover. He will join, he is busy with another session, and now he will join shortly. Now I request in the Dr. Salu to start her talk that punctal and canalicular tear. This is a common problem everyone faced. Nowadays is increasing day by day because of the road traffic accident, violent, and lots of other causes of injury. So now I request Dr. Salu to start her talk.
Dr. Shalu's talk.
Dr. Salu, yes.
Good morning, everyone. And I'd like to thank Dr. Das for including me in his course. So we all know that canalicular trauma is very common and may occur in all ages. However, the younger adults are more frequently encountered by this trauma. Mode of injury can be direct or indirect. The dog bite in small children is very commonly, we come with a dog bite injury and the canalicular tear. And in lactating mother, the blouse hook injury is very common in these patients. And basically and can also occur with blunt or penetrating trauma. The cadaveric studies has shown that as the medial canthal tendon encases the lacrimal system, so any injury or like blow with fist to the lateral canthus or malar eminence pulls the medial canthus laterally and thus tears apart it. Along with it, the lacrimal systems also tears. So like an avulsion injury, we can have this medial canthal avulsion along with the lacrimal injury. So these injuries can be occult and obvious, and we have to keep a high index of suspicion whenever we see eyelid trauma, especially involving the medial canthus. These are some of the examples of occult tears. So whenever in doubt, pass the probe either in OPD or take the patient to OR depending upon the age. And when we see the probe shining through the soft tissue, it indicates it's a canalicular injury. This patient presented to us with a pencil injury. There were small lacerations which didn't look very basically serious, but however we saw the tear appearing from here, and on observation, we saw that it's a direct injury from skin to the sac. So sac was open and need to be repaired. So it's a controversy which canaliculars to repair, whether to leave the upper canalicular. However, as 80% of drainage is through the lower canalicular, but it is believed and it's well written in literature that any canaliculars if injured should be repaired. Timing, early repair was preferred and advocated, but now with experience, it has shown that we can go and repair up to as late as 5 days or 72 hours. So basic principle is to identify the cut end, approximate the cut end around the stent, and retain the stent for adequate period of time. It's always difficult to identify the medial, if the cut end is medial, however the proximal cut end can be identified. So this is a medial cut end which we can see. So if it's not, we are not able to visualize the distal cut end, it's better to put all the tissue in the normal anatomical position. Do not inject too much of the anesthesia, it cause the distortion of the soft tissue, and then pass the probe. If you are not able to identify the distal curtain, you can use the method like passage of air in the pool of water, saline, or you can pass the saline itself from the normal canaliculus, or use the pigtail probe. However, I do not prefer pigtail probe as it has its own, causes a trauma to the canaliculus. The key is the use of high magnification and good illumination. So take the patient under the microscope and see, and in almost all the cases you will be able to find the medial curtain. Stenting can be monocanalicular or bicanalicular if both the canalicular are injured. However, you can do also the monocanalicular stenting if both the canalicular are injured, depending upon your choice. Stent most commonly used are the mini Minoka, which is used, or in bicanalicular Crawford stents are used. If we do not have the mini Minoka, we can go for IV intracath also. This was used earlier, but now as the mini Minoka is easily available, so we prefer to use the mini Minoka stent. So after passing the stent, the approximation with the pericanalicular suturing is very important. It is done with a 8-vicus suture, and then fixate the tube. Though the mini Minoka stent snugly fits into the punctum, however, in a pediatric age group, I prefer to pass 8-vicus sutures through the adjoining tissue so that they do not extrude spontaneously, and we have to take otherwise to the patient under anesthesia again. This is just to show the intracath fixation of the intracath. In this, the stellate is trimmed, the sharp end is trimmed, and it is used as a stellate to pass the intracath. And once we have passed it through the both the curtains, and then this is trimmed out, and then we are fixating it with the 4-proline suture. The first two sutures are passed through the stent and then to the skin, so that we can pull the stent away from the ocular surface, and we have an up and in traction. So the sutures are passed from the stent and the bolster, skin and the bolster, and then in the medial direction. This is just to show a patient who presented to us with a canalicular tear, but when we saw that there was a slit through the punctum, so the rest of the canaliculus was maintained, but there was a punctum we were not able to appreciate the punctum. So just a minute. So we passed the probe, and after localizing this curtain, and we passed the stent, and we sutured the tissue around it so that we can reform the punctum again. So the one anterior and posterior sutures were, pericanalicular sutures were passed so that we can reform the stent, punctum here. So another patient who had an upper canalicular injury with the lower, upper lid injury with a lower canalicular injury. And after identification of the curtain, the probe was passed. As this was an avulsion injury, so we passed the suture first through the orbicularis with the 5-vicus suture so that we can bring the lid in near to the curtains and then pass the stent. It's important that we bevel the curtain of the stent so that easily we can pass it through the punctum. This is we passing through the punctum and then through the curtain, and then do the pericanalicular suturing. This is just one of the examples of the patient with the avulsion injury with the canalicular injury. So if we take all the proper measures, we can have a high success rate as high as 95%, and the complications then are with infrequent or minor. So just take a proper steps, identify the structure, and then pass the stent, and maintain the stent for at least 4 weeks so that we can have a good success outcome later on. Thank you.
Dr. Salu, it's nice video, etc. But I have just some question to you. So if there is a bicanalicular very close, not a very far away, it is around 3 to 4 then what is your choice? You will go for a two stand or you will go for a single stand?
I'll prefer two stents mostly because I am not so much used to endoscopy, nasal endoscopy. If I have an ENT surgeon with me who can help me in locating the stent in the in the inferior meatus, then I'll go for the bicanalicular. Otherwise, I prefer for monocanalicular stents.
Yes.
Both are good techniques. You can, according to your surgical experience, you can do.
Yeah, we can. That's another, if sometimes there is a two injury. Thank you. So I just, another important point, are you using always a steel? It is, of course, it's very difficult to sometimes, because titanium, if that curtain is very proximal, generally I use titanium. So titanium is pretty little smaller, and there is a little good capacity to hold. And so in such scenario, we can use it, the titanium, if it is very proximal.
Titanium for what?
Titanium for instrument, forceps,
Yeah.
or that scissor, whatever, in titanium. Is
You
little
can use
better.
titanium forceps or LIMS forceps, whatever.
Yes,
Yeah.
to collateral injury.
And you should not pass the traction suture because it will distort the shape of the anatomy of the structures. So minimum anesthesia and no
Correct.
traction sutures.
Absolutely, and you are mentioning about the slit. This is the only challenges with heart. If there is a slit injury, not in a cut. If it is a direct, both the cuts are visualized is very, most of the time is easier. But it is a laceration with a slit on that, especially on the medial side, and that's the cause for unidentified on the table. So if any questions from the audience?
Dr. Shalu, I have a question. Like sometimes they stitch it in the peripheral center. Like if the patient is coming from far-off places, sometimes they do the primary repair over there, and they present late. So sometimes when it's like almost 7 days. And what is your take on that? Like sometimes very difficult to identify now. Once they have done a repair in the peripheral center and sent to a tertiary care center.
Yeah, we counsel the patient that we may redo the laceration, and we'll try to find the medial curtain, and all the techniques we use to find the medial curtain, if either the saline or the trypan blue, or we can. So most of the time it's easy to find, but if it's stenosed, then it's, we have to counsel the patient that they'll have Epiphora later on.
Yes, thank you, Dr. Salu. And I just address to your question one, that moment that Salu. So if there is a inflammation, after 5 days, 7 days, most of the patient reported. In such time, there is a lots of inflammation around. So if there is a more friable tissue, there will be some problems. So in such situation, we can wait for 2 weeks. Moment is healed properly. Or if there is an infection, our aim is to control the infection with proper antibiotic first. Then, if there is a 2 months old, 3 month old, not the issue, we can try our level base. In such scenario, we can just trim that wound little bit. Moment we can trim, it will be again fresh wound. That fresh wound will work like a new wound. So that's another technique. And we should use the microscope all that time. Now I request Dr. Rituja Kumar to deliver her talk.
Thank you, Dr. Jayanta Das, for having me in your session. So I'll be covering the pediatric lacrimal disorders overall, but mainly the pediatric epiphora. So I'll be covering it under these broad topics. So pediatric epiphora, that is because of congenital nasolacrimal duct obstruction, usually resolves spontaneously by the first year. And the issue is basically that when the canalization of the cord starts and is usually completed at birth, but doesn't get completed actually at birth or within the first few weeks, that's when you develop the epiphora. Now, the main causes of this are a membranous block at the valve of Hasner, or a stenosis of the opening from the narrowed NLD at the inferior meatus, or the hypertrophied inferior turbinate may be a factor, and any bony abnormalities which may develop later on. So some of the symptoms and signs which we most commonly see are, of course, epiphora, discharge, and matting. But as a result of these, you may have some amount of skin maceration, and of course, the Rho plus would be positive. So in infants, there are certain other causes of epiphora, such as blepharitis or congenital entropion, and of course, foreign bodies and corneal conditions and glaucoma. But what we'll be mainly talking about is the punctal and the nasolacrimal duct causes. So on examination, you of course do a Rho plus, but in children, you cannot usually do a syringing in the OPD. So you do a fluorescein dye disappearance test, wherein you instill fluorescein in the fornix, and then you can check for the disappearance after about 5 minutes to get an idea on whether it is patent or not. So when you check for dacryocystitis, you can again in younger children see issues such as these, which may be associated with some amount of respiratory issues as well. So it requires some amount of investigation before the diagnostic imaging, so it can be a confusing situation. But if you have a good anesthetist and you are in a multi-specialty setup, this would help. So up to 12 months of age, like I mentioned, you can have spontaneous resolution, but after 12 months of age, this tends to reduce rapidly, the incidence of spontaneous resolution. So we have conservative treatment and we have surgical treatment. So in conservative treatment, the Krigler massage or the hydrostatic massage, so the right way to do this would be not the way we advise. Some people I've seen advising pressing over the nose and then bringing your finger down along the nose. That doesn't really help. That's why it's called a hydrostatic massage. So exactly where the sac is located, it's important to go directly and press in that area right at the medial canthus to sort of increase the pressure in that area so any membranous obstruction can be overcome. So this is how you would advise to do a Krigler massage. You go in that area, you turn your finger, especially the little finger is used because that area is very small in children, and preferably doing it 10 to 15 times, 2 to 3 times a day. Now, when this doesn't work, the age for surgical intervention is usually after 1 year, or you could even wait for 18 to 24 months. So some of the invasive treatments, which are not too invasive, minimally invasive, I would say, is the probing with irrigation. So you can go ahead and do that with a Bowman's probe. Now, if a probing doesn't work, or if after a probing the child develops some kind of allergic rhinitis or develops the flu, that tends to get closed again relatively quickly. So you can do a repeat probing or a probing with intubation, a balloon dilatation, and of course a DCR after about 4 years of age. So when you do a probing, you look for whether there is a hard stop or a soft stop. A soft stop would indicate a canalicular, common canalicular obstruction. And usually this probing, like I mentioned, is after 12 months of age. However, people have done probing even at 10, 11, 12 years of age as well, and done it successfully when they've combined it with intubation, so that's another option. So how do you do a probing? You do a nice nasal packing. You need a meticulous technique for the passage of the probe, that is downwards, posteriorly, and laterally. And here you check for the spring test and do a confirmation of the patency. Now, it has to be, of course, done under a short general anesthesia, and the syringing is performed to check the patency. You can do a syringing which has a fluorescein stain or a betadine, so that when the suction is done, it would be visible in the suction tube. So again, downwards, backwards, and then finally laterally, so that you don't get a false passage and you confirm that you're directly in the nasolacrimal duct. So the success rate of probing, again, like the success rate of a massage or spontaneous resolution, decreases steadily with age, and the second probing has a lower success rate than the first probing. Now, after the probing, it's important that you advise topical steroid antibiotics, a nasal steroid spray like a mometasone, a good nasal decongestant, and a nasal saline, preferably for not a decongestant, but the steroid spray preferably for the next 1 month. Some of the issues which you may have is, of course, false passage and inability to actually pass the probe down. In older children, you may have a bony obstruction, so you wouldn't be able to pass the probe down. Entry into the submucosa. So where you actually want to come out is through the inferior meatus, but you may have a probe buried in the submucosa, and of course a failed probing, which of course happens in older age groups or because of any anatomical variations. Now, when there is an inferior turbinate involved, you need to do a medialization, lateralization of the inferior turbinate or a medialization together to sort of break that opening out. And this is again done under GA and a nasal packing. So you go ahead and you can go ahead and medialize it so that you can see this periosteal elevator here. So you go ahead and sort of move the inferior turbinate till you feel the click of that bone sort of cracking, and then you can widen this inferior meatus. So again, the confirmation of the patency is done in this way with the syringing. And when you need to do an intubation, there are several ways of doing it. We of course prefer a bicanalicular intubation, that's a Crawford or a Rittling intubation. And they have similar success rates, that is doing a mini Monoca versus a bicanalicular intubation. And this is usually reserved for when there is failed probing, and along with DCR in older children. I would say do a intubation in all cases of pediatric DCR. Now the issues that may come with intubation is difficulty in securing the passage, but if you do it under a good visualization, that is under endoscopic visualization, rather than just the metal on metal contact at the inferior meatus with your periosteal elevator, if you have a good visualization, you can be sure that you've reached the right area. Later on, you may have some partial or total extrusion of the tube, because keeping in mind that these are children, they may pull their tube out inadvertently. That is one of the issues which may crop up, but otherwise it has fairly good success rates if you pull out the tube after about 6 to 8 weeks. Balloon dacryoplasty is another modality in which you insert this tube, it has a balloon, and you sort of inflate the balloon for these periods of time. So that is 90 seconds, deflate, then 60 seconds, deflate, then again 90, 60. So that sort of widens this passage, and this is more effective when there is a membranous obstruction. Now probing, again, this basically you can see the lower end of the tube. Now it's important to have a good knowledge of the nasal anatomy when you're trying to do this endoscopic visualization. You should know where the, especially where the inferior turbinate is, and of course the middle turbinate. Now a DCR, I'll just quickly wrap up. The DCR is for unresolved nasolacrimal duct obstruction, especially in children over 4 years, and you can go through the external or endonasal routes. It's pretty much like a minified version of an adult DCR, but you may have some landmarks which are poorly defined. So it's important to use MMC and go ahead and of course do a stenting. Dacryoendoscopy is a newer method which was again discussed in some of the talks that we saw yesterday, and it again has a good success rate and hardly any complications associated. However, this is not something that we are practicing at the moment. So some of the recent opinions that we've collected based on some of recent studies is that advising sac compression for up to 1 year or 18 months of age is ideal. 2 years is probably the upper limit of advising sac compression. And it's important to use an endoscope during your primary probing, and use all 30% of people tend to use intubation even in the first case of probing, and it's better to repeat the probing, especially in a younger child, rather than going in for a DCR. So this is the overall algorithm of how to manage pediatric epiphora, and I thank you for your patient listening. I'm ready to answer questions if any.
Thank you, Rituja, for your excellent talk. You are rightly mentioned that we can go for. What type of anesthesia generally you, for the audience I'm asking, what type of GA? There's a lots of short GA generally. What kind of advice you generally?
So
to the
basically you need a short general anesthesia with an LMA is good enough, along with of course a throat packing, because you would be doing a syringing once you identify the patency. So a short GA with a LMA is good enough, and of course the anesthesia of the nose, that is the nasal packing, is also very important. That is with lignocaine and adrenaline.
Throat packing,
yes.
throat packing.
Yeah,
So I just want you are rightly mentioned one part that in the hardy anesthesiologist generally wants to do under a very without packing, just under ketamine. That may be very dangerous. So suppose some of your patient anesthesiologist wants to do under ketamine, straight away say no, because there is in case of an infant 11-month or 1 year, there may be a laryngeal spasm. It may be fatal. So it should be properly intubated and with a tracheostomy, with tracheal tube, endotracheal tube, with cuff. There is a term. In such scenarios, no need for any packing, no need for the gauze packing. Gauze packing also little difficult, and in a pediatric need a very soft type of gauze which may not be available. One of the disadvantages is that with endotracheal tube with cuff is little expensive one. But from a pediatric point of view, for a life, one life and one child, that is a single child norm. So better we can go for that facilities, and we should instruct our anesthesiologist one. Rituja rightly mentioned 3 points like that. We can go for a regular massage moment. If we can treat maximum number of patients, those are failed by spontaneous, then patient we can almost 90% we can treat by massage. But unfortunately, most of our ophthalmologists, even the pediatrician, they are telling that earlier our teaching was to just massage on the nose. It is not the way. Rituja rightly mentioned, it should be a hydrostatic pressure should be generated inside the sac, and it is enough to rupture that membrane. That's all. Now I request Dr. Nilanjan to start your talk.
Thank you, Dr. Jayanta Kumar Das. My topic is the magnitude of lacrimal diseases in the community. It's not moving. Okay. So there is no financial interest. So we all know that the lacrimal apparatus, it consists of the lacrimal gland, lacrimal sac, and the nasolacrimal duct. So this is a conditions dacroadenitis, which is very uncommon, and it is found in 1 in 10,000 ophthalmic patients, mainly identified in children and young adults, and is associated with autoimmune diseases. So coming to the lacrimal gland tumors, these have a yearly incidence of 1 in 1 million, representing 10% of the orbital space occupying lesions. You can see this, the overall breakdown of the lacrimal gland tumors, non-epithelial highest with 75%, and the breakdown of benign and malignant, benign is 55%. Now the lacrimal drainage system is a complex apparatus responsible for the flow of tears from the eye to the nasal cavity. Now, any pathology of the system usually appears as watery eye. Now, we all know that it may be congenital or acquired. Now, nasolacrimal duct obstruction is the most common disorder of the lacrimal system, leading to acute or chronic infections. It can occur just after birth or in adults older than 40 years. Now, what are the diseases which leads to epiphora? It can be legophthalmos, canalicular or nasolacrimal duct obstructions, dacrocystitis, etc. Now, what are the risk factors? Older adults are at increased risk of developing blocked tear ducts, chronic eye inflammations, any previous eyelid surgeries, nasal surgeries, or sinus surgeries, patients undergoing radiotherapy or chemotherapy.
Now coming to the prevalence of lacrimal diseases in India. So data is very limited. So this is a prospective study carried out in northern India. They found the prevalence of dacrocystitis was 19.5 cases per 10,000 patients, and the incidence rate was 15 cases per 10,000 patients. This is another observational study done at Orissa, and they found the prevalence of chronic dacrocystitis was 1.224%. This is a retrospective, 5-year retrospective study done at LVPI Hyderabad, and where they saw the records of 20,000 patients. They found primary acquired nasolacrimal duct obstruction was 51.56%, followed by congenital nasolacrimal duct obstruction. The most frequently encountered proximal lacrimal disorder was punctal stenosis. So maximum chronic dacrocystitis presented in the 6 to 7 decade of life, and it belonged to the lower socioeconomic status. So these are various studies which have shown the frequency of NLD, acquired NLD obstructions in male versus female, and a lot of studies have shown that females are more affected than the males. So this is another study from LBPI. So it is it was a retrospective study of patients presented with acute dacrocystitis. So they found to be 2.4%. 23% of eyes presented with lacrimal abscess. 5.6% had fistula. 2.8% had orbital cellulitis. Now coming to the microbiological profile. So a prospective study from Karnataka found the predominance, they reported gram-positive bacteria to be the most common, that is coagulous-negative staphylococci and Staph aureus. So this is my own study in southern Assam. So where we found in chronic dacrocystitis, the most common organism was Pseudomonas and Staph aureus, and in acute, it was Staph and mixed flora. A similar study was done by Jayanta Das et al. In Northeast India, showed similar microbiological profile. Majority of the microorganisms were gram-positive with a predominance of Staph species, Staphylococcus, and most gram-negative was Pseudomonas. Now, in another microbiological profiling study, acute versus chronic in Arvind Eye Hospital, they found that 70% were with chronic dacrocystitis. The proportion of Staphylococcus aureus and Pseudomonas was higher in acute, while proportion of coagulous-negative Staphylococcus was higher in chronic. Now, what is the source of infections? So there was a study by Jayanta Kumar Das et al., retrograde or antigrade. The source can be from the conjunctiva, from the nasal cavity, from the sinus, etc. Now that study showed that maximum growth was in the nasal mucosa, followed by the lacrimal sac. Last is the conjunctiva. Now what is the reason for high prevalence of dacrocystitis in the society? Because it is seen that majority belonging to the poor socioeconomic status, poor workplace environment, poor hygiene. It also contributes to the poor knowledge regarding disease condition and awareness regarding maintaining good hygiene. Now this is a report of primary tubercular dacrocystitis. So it was reported in Orbit, where it's a case of 15-year-old female with a history of 8 months of Epiphora. So biopsy from the lacrimal sac revealed tubercular granuloma. So this is another report which was seen in UK, reported from UK. 2 children presented with acute dacrocystitis showed clinical and laboratory features of Epstein-Barr virus. So these are my references. Thank you so much.
Thank you, Dr. Nilanjan. There is some always why, there's a question in our mind, why it is more common in women. That is another one, established one, that is a little, not as very significant anatomical variation amongst the female. But another point is, it is from a lower socioeconomic condition is more common because unhygienic condition and less amount of water they are using to clean the face, and then there is no such wash basin in the home, and there is always crisis of water in some areas, there are more. Recently, another point is that there is a tendency for the woman is a long nail always, may carry lots of infection. Another factor. In my all patients, I generally examine the patient of the nail, found in whatever, irrespective of the age, if there is a nail is long, all patients out of the 100, if we concentrate 70% of them patients, there is a long nail. So we can educate them, so if you make your eye hygiene more disease free, so make it a short nail. Okay, thank you, Dr. Nilanjan. I will cover some, pardon sir. Sir,
practically, is it possible to wait for the culture sensitivity report to come, or we will give
no,
some antibiotic?
we can start a antibiotics, specially covering both gram-positive and negative cocci and bacilli. This is our. Okay. In acute, those are maximum are in sometimes Klebsiella also, or so our aim should to cover gram-positive, negative, etc. whatever antibiotic available, and ideal approach is that whatever, if there is an abscess, or if you can collect some amount of discharge, whatever, you just send for first culture and sensitivity. But unfortunately, most of our patients, they are already treated somewhere with some drops for a long period. In such scenario, little difficult, and hence our another problematic situation is our lab facilities. Yeah. If you send pass, I have some experience, frank pass to the lab for culture and sensitivity, found sterile. So whatever, if you just, that is my take home is the message for to everyone. So I just collect it in myself in a plate. I just ask them for the plate, and it will be placed on myself, because if I send the sample to the lab, what they will do, the technician will store it in a very cool, or in the table, not in the table, in a very cold chamber of that, more secure. Moment the organism may die. Maybe those are the factors. So in our setup, basically we should go for antibiotic immediately, or we can wait for culture and sensitivity.
So personally, what do you use, sir?
I am doing both. If there is a abscess, there is no need to wait. My first is that check the pressure, sugar, and the BTCT, and immediately I will go for abscess drainage. Moment you can go for abscess drainage, you can control. It's a huge sac, inflamed sac. Moment you can reduce, if it is ruptured by its own, the patient can save some amount of money, but that sac may rupture in a different way, which may be very difficult for next subsequent surgery. Or next option is that if that patient can afford, now my approach is that I am going for endoscopic immediately. If all parameters are no need to wait, very fantastic results. One of my video is there, but I am unable to do the download because of the large file. Sorry for that, but I want to. So if nowadays, if you do a endoscopic this year, and you can drain it out all passes, and moment you can drain the pus, and at the end of the surgery, it will little settle. So you can intubate, or without intubation also, that surgery can be performed. So it is a fantastic result. This is the only indication for endoscopic surgery. So if patient can afford, my protocol is we can go for endoscopic. If not, if there is abscess drainage. But if abscess is almost about to rupture, in such scenario, you can just drain the abscess, and you can go ahead, wait for 6 weeks.
My concern is, sir, what should be the empirical antibiotic?
Empirical and
applicable,
generally,
it depends on empirical, sir, should depend on the place.
Yes,
and
yes, yes,
the
yes, yes.
organism
Oh, you are
there.
asking.
It may differ from Delhi to Calcutta to a small
Yeah, the
village.
cephorexim sulbectam. Sulbectam, you can include the sulbectam, cephorexim or ceftriaxone with sulbectam. It will cover almost all.
Okay.
Please choose the sulbectam and the other, whatever, because the third generation or fourth generation with the sulbectam or tobramycin injection, it is work very good.
Okay.
It is easily, for theoretical point of view, practical point of view, tobramycin or amikacin, or sometimes amikafenco. But amikacin, tobramycin or sulbectam or in one group or
So we
cephorexim,
can
that's
use
one.
also systemic antibiotics. for
Systemic, always systemic. No role of any topical if there is a
topical,
acute.
oral.
All
can continue.
oral you can give, but in preferably in injectable. Preferably in injectable, always injectable.
Okay.
And and our aim is to reduce the inflammation. Hot compression is a mandatory, and general status. What is the systemic status? What is blood, hemoglobin, sugar, etc. Sometimes there is a 400, 500 sugar with acute decrocystitis.
Yeah.
And there may be hypertension. Those are we can control.
Okay, sir. Thank you.
Yes, sir. Thank you, sir, for your. Question, sir. So there is some unusual, we generally overlooked some points. I want to highlight those few points. So as Rituja already covered, I will not go for, but level. To treat the Epiphora, we should know the level, at what level that obstruction. Canaliculus also, if it is at 10 mm, membranous obstruction, we can go ahead with DCR. But if it is a proximal or it is a midsection, then we can we can cut that, identify, and we can do a reanastomosis, kind of like a tubectomy gynecologists are doing. We can do that also now with a lesion device. With a Salu mentioned mini monoca. Mini monoca is expensive little. So generally oral offered, that is very in a reasonable, that roughly for the doctor's price is around 3,000, less than 3,000 even you are using more. So those are the points I want to say. Lacrimal puncta lies 6 mm from medial canthus, edging from lacrimal leg, and both are almost 0.5 differences there, so we can identify. And punctal stenosis or agenesis are one of the commonest cause of Epiphora. Most of the time we overlooked. So we can assess on the slit lamp puncta, and there is a point is that punctal snip, punctectomy actually, it can make a snip by titanium. It may be a single, it may be a double, or it may be a 3 snip. So if it is a 2 snip, it is V, only a single clot 1 snip. And nowadays with the stent, we can treat. Generally my advice is, I am doing right now with the stent, because that OT surges are high nowadays in every setup. So we can go for a stent or the punctal plug at least. And we can use a mitomycin C also, but a proper punctectomy is the point. This is actually is a earlier era. There is some nowadays we can identify by in a OPD setup. This is a decrocystogram. Most of the time is not required, and there is a technical issues also with the decrocystography and decrocystogram in CT decrocystogram, because none of the radiologists are tuned for. There is a lack of punctum on that. If you are sending, they will not get any appointment with the radiologist. So many issues. So just I develop in myself to evaluate the canaliculus and punctum. This is the kit. If you have a endoscopy is well and good, you can do a endoscopy also. But if no endoscopy, nothing to worry, just you need a one nasal speculum and then one forceps, and either in a caliper or in a plastic ruler also enough. But you need a set of puncta and dilator and a probe, one plain forceps. That's all. Nothing is required. So I will explain how. Just under microscope or slit lamp, dilate the punctum, visualize the punctum, then dilate the punctum and introduce the probe. If it is hit on the bone, so nothing to worry, there is no canalicular obstruction. But if there is soft stop, just mark with your plain forceps and pull it out and measure with a plastic ruler. If you have a caliper, well and good, your assistant can help you. Otherwise, you just yourself you can do in a plastic ruler. If it is a 8 mm, so you can go for a canalicular-decrocysto-rhinostomy. But if it is a 10 mm or 9 to 10 mm, it is definitely it is a membranous obstruction. But less than 6 is really a very, very challenging for you. So this is a very practical, very, very easy OPD procedure, no need for any infrastructure, no need for any huge cost instruments. So we can detect it properly. One of the cause for fail this year due to the not properly evaluated as per the American Academy of Ophthalmology. Just they are accept it that it is our fault, and it is the in spite of the good drainage system, and most of the ENT surgeons are nowadays doing endoscopic, and because of this their failure that is more because they don't know how to handle that part. So surgical technique, you can go a mitomycin C. You can use it after punctectomy. If there's a punctum is small, you can just toss in 1 minute is enough, and or either you can go for a stent. So this is one of my, it was not, in the left it was not visible almost. Now after the punctectomy with a mitomycin C is at a 1 year follow-up. Sometimes that may happen. That gentleman came to my OPD. This type of patients are still, I have a 7 number of patients. There is a Epiphora. If you look, there is a fall. That is just one eyelashes is in the one punctum, and it's erode, the rough is erode. There is a tendency from the leg, which is a smaller part of the eyelashes, pointed one will go inside, and the rough, which is not, it will be engaged in the punctum, it will hit. If you look at that punctum is injured. So there is a Epiphora for last 4-5 days. He was treated several times, and then it was overlooked, and somehow I just identified and removed that one. Just remove with the punctum, and anti-inflammatory antibiotic is enough. So this is the point 1. So not always a sac enlargement of the hair area is a lacrimal, the chronic decrocystitis or mucocele. In this particular, no Epiphora at all. There is a swelling. Someone sent me through for a look for a decrocystitis, and when I examined the patient, it was no tenderness, nothing is mass, and there is no Epiphora. Then I did the syringing. Syringing through the upper punctum was through freely patent, and lower punctum there is some amount of resistance. Mild Epiphora only, she just complained. Then I did one CT scan. There is a lump. Radiologist again mentioned is a lacrimal sac mucocele as usual. Then I think and try to operate like I want to explore what is this. Just explore. There's a whitish mass is there, and then I remove. I thought it may be some lymphoma or something, whatever. But it is, but in toto, it was removed in toto. It was mass was like this. So what to do? Then I just observe in the OT. It is not looks like a lymphoma, nothing. So what to do? I just open it up. It was like a sac. I just open it. Moment I open it up, that's a worm. That worm was thalassia. It was a living. It was just moving. You see that moving. Just stored in a bowl and sent, and it was found as a rare, it is a thalassia. It was published in the journal also. Sometimes there may be a growth around that may be nevus. Patient may be conscious rapidly enlarging what to do. In such scenario, we can go for a identify the punctum, excise the punctum, reconstruct the punctum, and later on I can just intubate it for either a single point intubation is enough. So those are the points. Another, it is a growth around the punctum. So in such scenario, if you try to excise in a very rough way, then there may be injury to the punctum. Our aim is to preserve the punctum as much as possible. Of course, at the end, we should go for with a stent. So what I just observe gently, and with the help of the venous, just dissected with the tip of the venous. I just observe all with the tip of the venous. Dislodge as much as possible. Then you can at the end you can pull it out. The rest of the thing we can pull it out. You can cut. Always use a venous in such good quality, or either a good quality small scissor, so to avoid any damage to the, then you can, and that was up to the inside the punctum also. Then there is a bleed, no need for any cautery in such any, then you just wait observe the bleeding and press it, use mitomycin C, or you can do intubate in such a, I will not go for this, as Rituja already mentioned. So I already in my slide mentioned at what level. This is a diagrammatic representation of the membrane. Membranous obstruction is there. So if there is a membrane, what to do? We can go for direct surgery, as time is little up, so I will go for, and that is a beauty, as sir already asked, that what we can do in a acute on chronic necrocystitis. If we, with the antibiotic, if we can control, then we can just remove that thing, and we can identify the membrane, we can remove, and that is the steps. I want to show you moment. This is in external approach. But if in a acute stage, we can go for a yes. And then specimen I already addressed your even in the OT also. We can just in whatever culture, this is a term as a transport media. That means all organisms may grow here. Then accordingly, after 24 hours, even 48 hours, they can transfer to the in an appropriate on that basis. So it will avoid to damage the bacteria. It will not kill. It may be dry. It may kill, or if it is very cold, it may be sterile. So this is a sample collection system. So Dr. Nilanjan already mentioned, I will not go. So we can think lot. There is a lots of things in we can think, and accordingly you can go one by one. Thank you. Now, so that is my take-home message, is that detailed knowledge about pathogenic organism and their source, along with the spread of, it will help we can identify the pathogenesis and proper care, and ultimately as a whole, the thorough evaluation as the key and proper selection of your mode of treatment. Now I request Dr. Please come. Amrita is a consultant of our Sir Gangaram Hospital, and she will speak her talk next. And next is our Dr. Grover sir.
So, morning everyone. Thank you, Dr. Das, for the opportunity. I will be talking about external and conjunctivo-dacrocystorhinostomy. So DCR, as we all know, it's a bypass between the lacrimal system and the nose, and it can be performed by removal of the bone between the lacrimal sac and the middle meatus, and then creating an anastomosis between the sac and the nasal mucosa. It can be done via the external and the endonasal approach. However, I will be discussing external in detail. Indications, primary and secondary, acquired nasolacrimal duct obstruction, persistent congenital NLDO, NLDO associated with chronic dacrocystitis and mucocele, functional epiphora, and the canalicular obstruction. So we need to confirm the diagnosis by syringing and probing, examine the ocular surface, eyelids, puncta, in presence of any fistula, any scarring, any telecanthus, which can be dealt along with the external DCR. And in case of any previous fractures, the osteotomy could be challenging, so you may need a chisel and hammer ready. Another important thing is whether it's a unilateral or bilateral case. Bilateral case definitely warrants a biopsy to rule out any underlying systemic causes, and nasal examination is of utmost importance. Before taking up the patient for surgery, we need a thorough pre-anesthetic checkup. The surgery can be done under local or general anesthesia. However, majority of the cases can be done under local with 2% lignocaine and adrenaline along with hyaluronidase. If the patient is under local, we need to give topical paracaine along with local infiltration at the incision site, which must be marked before you give the local block. Now, nerve blocks have become extremely important in any oculoplastic surgery. So we can see the first division, that is ophthalmic division of trigeminal nerve, enters the orbit through the superior orbital fissure and then further divides into the frontal, nasociliary, and the lacrimal. And the second division is the maxillary division, which enters the orbit through the inferior orbital fissure and then emerges as the infraorbital nerve. In case of external DCR, the important nerve that needs a block is the nasociliary nerve. The branches are infratrochlear, anteroethmoidal, and the dorsal nasal. They together supply the lacrimal sac, medial canthus, and the lateral aspect of the nose. For the infratrochlear block, we can see that the needle needs to be inserted just below the trochlea and above the medial canthal tendon along the medial orbital wall to a depth of 1 centimeter. For dorsal nasal block, we need to give a subcutaneous block 3 millimeters medial to the medial canthus, and for anteroethmoidal, we can go transcaruncular along the medial wall at the depth of 2 centimeters. For blocking the infraorbital nerve, we can actually palpate the infraorbital foramen, which is 1 centimeter below the rim, and then we can block the medial branches. So another important topic is hemostasis, which needs to be achieved during and after DCR. So adequate nasal preparation needs to be done with the nasal packing. If the patient is under general anesthesia, you can place them on the reverse Trendelenburg position. Slight hypotension is ideal for GA, and throat pack is a must. During the procedure, we must have gel foam and bone wax ready, and intraoperative tranexamic acid is also very useful. Now, the important thing is that tranexamic acid is going to prevent the clot breakdown. So it is not a pro-clotting drug, but is going to prevent the clot from being broken down. So IV is a routine method. However, recently we have started adding 1 ml of tranexamic acid in the local infiltration. It still has some amount of risk, so even recently we have started pouring it over the surgical site, which reduces the risk of thromboembolic events. Steps of the surgery, so incision is marked, which extends 2 millimeters above the medial canthal tendon, and then further extending 12 millimeters below along the anterior lacrimal crest. Subcutaneous dissection is done, then the orbiculus dissection is done, and the periosteal incision is given along the anterior lacrimal crest along with the release of the crus of medial canthal tendon. Then the Freer's elevator is used to elevate the periosteum, reflected laterally along with the lacrimal sac to expose the fossa here. And then once the fossa is exposed, like you can see in the video below, we create a bony opening in the lacrimal bone, which is a thinner bone of the fossa, with the Freer's itself. Then the ostium is enlarged using kerrison bone punch, superiorly extending to 2 millimeters above the medial canthal tendon, anteriorly 10 to 15 millimeters anterior to the lacrimal crest, and inferiorly we need to partially deroof the lacrimal canal. And the nasal pack should be removed before enlarging the ostium. Post that, we need to probe the canaliculus, and then we need to stent the lacrimal sac. The important thing is the probe should be bent in such a way that it tends the sac as posterior as possible, so that we can have a larger anterior flap and a smaller posterior flap. Once this is prepared, then we can prepare the nasal mucosal flap, and finally the posterior flaps can be excised, and we can suture the anterior lacrimal sac flap with the nasal flap. Now, if we need lacrimal intubation, then it needs to be done before suturing these flaps. Following this, orbicularis and skin closure is done and the nasal packing is done. Now please note, this nasal packing is not as deep as the pre-op. So the indications of intubation, intrasac sinus, any redo surgeries, complicated surgeries, canalicular pathologies, and inadequate flaps. The intubation could be monocanalicular or bicanalicular. Monocanalicular is very useful in children because it's easy to remove. These stents were actually very useful during COVID times because the endonasal intervention wasn't required during the removal. Mitomycin C use has similar indications. Now coming to conjunctiva DCR, where we are basically making a new passage from the conjunctiva into the nasal cavity. It can be done through external approach and endonasal approach. However, we prefer the endoscopic DCR followed by Lester-Jones tube intubation with Scheldinger technique where we use a central line kit. Indications, punctal and canalicular agenesis, proximal canalicular obstruction, failed DCR, pump failures, and post-dacrocystectomy rehabilitation. It should be avoided in cases where there is a scarred medial canthus, eyelid anomalies, early childhood, patients who are not willing for regular follow-ups or tube management. Now steps, we basically perform the procedure under general anesthesia where we first do endoscopic DCR. Now the debate is whether or not we should open the sac. Now in my opinion, since sac is an enclosed epithelial cavity and if you disturb it with a foreign object like a tube, it starts secreting more and more secretions. So it is better to open the sac just like any other DCR. The next step is medial carunculectomy, which is quite critical before inserting the Lester-Jones tube with preservation of the plica. Then we come to the Scheldinger technique. So this is the first equipment which is called the trocar. If you can see in the diagram on your extreme right, so the trocar is passed flat onto the coronal plane and should practically indent the cornea, and the entry point is posterior to the mucocutaneous junction very near the lacrimal papilla. Now why this position? It is because we want the trocar to, we want the trocar to enter along the anterior end of the middle turbinate. So if you see the endoscopic guidance, it has to be done under endoscopic guidance. We see the trocar entering the nasal cavity. The next instrument is the guide wire. So this instrument, it can be advanced and retracted with the thumb. And we place the guide wire through the trocar into the nose. And with the help of endoscope, we can actually see that the guide wire has entered the trocar and into the nasal cavity, and once it's in place, we can actually retract the trocar. The next is a dilator. So dilator is again passed over the guide wire, and then it actually enters the nose. We can see here the dilator entering the nose. Another use of this dilator is that when in the nose, we can mark it, and later on, we can measure it to know the adequate length of the Lester-Jones tube. And finally, we have the Lester-Jones tube, which adequate size selected can be slid over the guide wire and finally into the nose, as we can see here on the right. There's a tube in place, and once we know the Lester-Jones tube is well sitting inside the nose, then we can remove the guide wire. Once in place, we can also check the patency by syringing. So we can just put some fluid onto the conjunctiva, and we can check the drainage of the tube. Once in place, we can hold it in position with 6-0 non-absorbable suture. So like we can see here, the suture is around the neck of the tube and it is brought out over the bolster. The suture and the bolster can be removed after a week. This is very important because if carunculectomy is done at the same time as Lester-Jones tube, then the tube tends to sink beneath the conjunctival healing, and the patients do very well. Post-operative care, like any DCR, avoid hot fluid, spicy food for 48 hours, avoid any strenuous exercise, nose blowing for 2 weeks. Oral antibiotics and analgesics along with topical antibiotic steroids should be given. Now, if the patient has Lester-Jones tube, you have to ask the patient to put in one of the drop of saline or the hypermilose on the same side, close the nostril on the other side, and sniff in the fluid on the side of the tube. That helps to keep the tube clean. And when the patient is going to sneeze, the patient should put 2 fingers over the tube so that it shouldn't get displaced. Follow-up post-op day 1 nasal pack removal is done, suture removal after a week, and if there is any stent, it has to be removed after 8 to 12 weeks. For patients who have Lester-Jones tube, the syringing in clinic is a must, so you can call the patient 6 monthly and then annually for syringing. Complications, bleeding, hematoma, wound dehiscence, infection, scarring, tube-related complications like migration, extrusion, blockage. Lag of thalamus can occur in case of external DCR due to the damage of facial nerves, persistent epiphora, and failed DCR because of some syndrome. So a thorough knowledge of the lacrimal, eyelid, and nasal anatomy is needed to perform DCR successfully, and a surgeon must be well versed with all the methods to control the bleeding. Thank you very much.
Thank you, Dr. Amrita. And now I request Dr. Krupar sir, please deliver your talk. So, sir will speak what are the new things in our dacryology.
Good morning. Thank you, Jayant, for making me a part of this course. I'll be speaking on some of the newer approaches in management of lacrimal diseases. We'll talk about some entities in congenital nasolacrimal duct obstruction, like some of them not so new but used more often now, like inferior turbinate infracture, balloon dacryoplasty, and the endoscopic assisted probing of late has become a very useful tool for management of congenital nasolacrimal duct obstruction, almost becoming a routine in the more difficult cases. For the acquired obstructions, use of botulinum toxin for punctal or canalicular obstructions has become much more common. Canalicular obstructions, many of them can be tackled with Sisler trifines, and conjunctival DCR has become more defined because of new tubes and new techniques which have already been elaborated upon by Amrita. For acquired nasolacrimal duct obstruction, endoscopic DCRs have become more in vogue with better results than were reported earlier, approaching the success rates of external DCR. The non-endoscopic transnasal DCRs have also been used quite significantly now, even in pediatric cases, and transcanalicular procedures, including recanalization of the nasolacrimal duct, are also important procedures now. In the management of failed probing, a repeat probing is often carried out after an interval of minimum of 6 weeks, and inferior turbinate infracture and balloon catheter dilatation have become more important tools in these cases, and virtually all of these cases would now be done under endoscopic control. So the important thing about inferior turbinate anesthesia is that you do a vasoconstriction first by nasal packing. We learn from our ENT colleagues that they use very high strengths, up to 1 in 5,000 or 1 in 10,000. And what is important is to realize the anatomy of the inferior turbinate, which then needs to be rotated away so that the inferior fossa becomes much more accessible and visible and allows you a direct visualization of the probe and manipulation of the silicone tubes if you want to carry it out. Balloon catheter dilatation has been there for quite some time, but has been in use in specific cases only over this period of time. And it is used both in previously failed cases as well as primary cases. The advantage is that the dilatation forces are directed radially rather than longitudinally, and they are more effective and produce less tears. Now, the success rates of 77% versus 84% intubation are not that great, and they are costly. So the use has remained rather selective. So balloon sizes of 2 and 3 millimeters are available, the larger one for the older subjects who are more than 2.5 years old. And the 2 cycles of balloon inflation are carried out both at a distance of 15 and 10 millimeters. And this is the device where you have an inflation which is done by air injection, the pressure you can make out, and this is the balloon that dilates, and at the defined pressures that we spoke about, this dilatation is carried out after the probe and the balloon is in position. And this is how the pressure is maintained for the required duration, and then it is removed. Now, nasal endoscopy is very useful and is probably the most important gain in probing, which has improved success results in complex cases to very close to 90-95%. As you will see here, 94 to 97% is a very high success rates even in complex cases where the opening of the probe is not directly into the passage but maybe submucosal, and all cases where there are nasal cysts or other associated pathology can be directly tackled now. Let's look at an example now. This is a probe being passed, and rather than being blind, we see the inferior turbinate, we rotate it away so that now the inferior fossa is much more spacious. We can see that the probe is pushing the mucosa rather than coming in through a obstructed nasolacrimal duct opening. So we have to open it with a sickle knife, as you're seeing here. And once we open it with a silicone knife, with a sickle knife, we're able to see the probe actually physically present there. So now we are much more sure of what to do in these circumstances, which are complex. And once we have created an artificial opening, it is important to retain a stent in position because otherwise it would fibrose. So silicone intubation is carried out, which is also much easier under direct visualization of endoscopy. For the acquired obstructions, punctal stenosis has seen a sea change where our conjunctivodacrocystorhinostomies have dropped down almost 500%. And we do hardly a couple of conjunctival DCRs in a year now because of the availability of botulinum toxin. 2.5 units is generally used, injected transconjunctivally under topical anesthesia into the palpebral lobe of the lacrimal gland, and the results are very gratifying with almost 60 to 90% patients being significantly better. And this is true both for anatomical obstructions of the upper lacrimal passage as well as functional Epiphora cases where some of them a surgical procedure may be avoided. The effect usually for our patient is mean of about 6 months. Usually about 3 injections are needed, and many of them would not complain after 3 injections or will require much less frequent injection of Botox and get a permanent result. So transient ptosis is the only common complication in about 8% cases. Other complications are rare. This would last only about 4 to 6 weeks. And we have done over 200 cases now, and with very high success rates of over 90% with an average duration of 6 months. Now the obstruction in the upper canaliculus or punctal obstructions, there are a number of procedures, but the ones that are more commonly used are punctal opening with plugs or intubation, snips or snips with intubation. Now, the availability of perforated punctal plugs from FCI is one very useful method which allows the drainage to take place while the newly opened punctum can remain patent. Snip procedures are relatively less often used now, but in some situations they are very useful. Like you observe here, we can hardly pass our probe to any depth. Now, many of these cases would not work with a single snip as well. If it's just a punctal stenosis, then a single snip would work. But in cases like these where we found no patency after the single snip, a 3-snip procedure still may have relevance. So here we have given a horizontal cut, and once we join, after the first 2 millimeter vertical cut, this horizontal cut along the direction of the canaliculus is given, and then the two are combined together to create a 3-snip. Fortunately, in this, after the 3-snip, we were able to find patency and carry out an intubation. So this is the completion of the 3rd snip, and you can see that the probe can now be passed so that intubation is now possible. So of all the techniques for canalicular blockage, cisplatin seems to work well for middle canalicular obstructions, single obstructions, usually at about 4 to 6 millimeters. And this is the trephine. Once you pass, you remove the outer shell and you allow the trephine to go through the obstruction and then carry out an intubation. This has reasonably good success rates for isolated single obstructions at about middle of the lacrimal canaliculus. So conjunctival DCR has fortunately been covered well by Amrita, and we will not need to go into the various options, advantages, stop-loss tube, indigenous tubes that we get it made, and the technique and the newer approaches of direct passage. So we will avoid these videos as well. Transcanalicular laser DCRs and endonasal DCRs have also given a significant change in the scenario of surgical management. So the use of silicone intubation, mitomycin C are points which are debatable, but increasingly in failed cases, mitomycin C is consistently used with good advantages. Endonasal has become much closer to external in its results. Thank you very much. Grateful for the invitation to be part of this course.
And you can ask, or actually we got that hall after 12 minutes behind the schedule, and we are happy that at least we can cover 6 minutes, and we are handing over our session to the next session at least only by 6 minutes behind the schedule, but we got that hall 12 minutes. Thank you. And I just request our speakers for a group photograph.